Hello, everybody. We're going to introduce you a foreign study. Two groups from Italy will share their experience with our system for sepsis. First presentation will be focused on the scientific background of our experience. And the second one will be a practical one, speaking about the results, the clinical results impact of the study. Thank you.
So thank you very much. Welcome, everybody. I am a medical microbiologist, and actually I'm going to share my personal experience with several molecular-based approaches on sepsis. What is our goal when we work with this kind of approaches? Obviously, there are both clinical and economical aspects. And even if it is counterintuitive, using more expensive assays, such as the molecular ones, I would like to start with the economical part of the story, because we have experience in studies with other assays that's allowed to say that it is possible also to save money when using more expensive tests. As a matter of fact, when we approach to sepsis, we have as a gold standard something which is not a gold standard, which is blood culture. But that has to be somehow a reference. And even when we start bypassing blood culture, which will be the topic of today's lecture, you will see that there are several aspects that have to be considered. As a matter of fact, I don't know how many of you are familiar with this panel. This was the so-called Septifast assay, which was distributed, then abandoned about 15 years ago. And we were among the first worldwide users. And as you can see here, there was a limited panel of microorganisms. And I'm sure that everyone among you will also notice that there are no genetic markers of antibiotic resistance. And as a matter of fact, we performed a propensity score matched economical study in which we showed that even using that very limited approach, we had an overall save in terms of costs. In particular, for example, we spent a lot of less in empirical therapy, but also in other technical and diagnostic approaches that we had to use. So there was an overall saving. And we're talking, again, of an approach that was, under a clinical point of view, very limited. So let's move to, as a clinician, is what is more important to us. What is the approach and what is the goal of using molecular biology-based approaches on blood? Certainly to have a quicker diagnosis, to allow a rapid and so quicker start of therapy, but also to allow us to modify for example, antibiotics that we have already started. And there are several studies which shows that this has a huge impact, that antimicrobial stewardship based also on this kind of approaches has a huge impact in terms of decreasing mortality, sepsis-related mortality. Also in this case, we had an experience with an assay which is still used, but compared to the previous one, started on positive blood culture. So this is the major limitation of this kind of test. As you can see here, the panel was somehow broad, and most importantly, you had here, this was one of the first assays that included also genetic markers of resistance. Also in this case, we performed a clinical utility approach. We also had economical data, but now I want to focus on the clinical part of the story. And we understood that even when starting on positive blood culture, so not directly on blood, we had 20% of cases in which we would have changed therapy if we would have used that kind of approach, starting on positive blood culture, so not directly on the sample. And this is a more than 10 years old study, which we concluded like this. However, we are convinced that a real revolution in the microbiological diagnosis of sepsis will occur only when an assay with the potential of the one investigating this study is performed directly on blood samples, which was something that we already had experience about but that we had somehow also somehow renew. As a matter of fact, also in this case, when we start on positive blood cultures, we have to consider that this is something that everyone has to be aware of, that when we have a molecular-based assay in our lab, we just don't have it. We have to integrate it with all the other assays we have in hand. Just to give you an example, a possibility is also to include, to understand if that approach may be useful. For example, comparing it to other phenotypical approach, for example, such as, quick AST on rapid antimicrobial susceptibility testing on positive blood culture. So, as a matter of fact, when you have this kind of assay in a lab, you have to consider if they are really useful and also in this case, we concluded the study reassessing the importance of having something starting directly from broth. What do we have directly from broth? Under a commercial point of view, there are some novelties here in this Congress as well, but we had several, commercially available assays, some of which also have been, discontinued in terms of commercial use to do assay in a sample, and all of them have the problem of being extremely expensive. So how can we, cope with this kind of problems? Try to improve the clinical impact of the whole story. And this is the reason why I'm here. So I was in contact with Anatolia. We proposed a clinical study on a very, highly specific setting of patients, which are solid organ transplant patients, in which we decided to use not only the Anatolia gene work approach, but to use several different approaches, including, for example, immunological markers, which will allow us to potentially, maximize the usefulness of this kind of molecular-based approach. And as a matter of fact, we are still enrolling. We have enrolled more than 130 patients all over 5 centers in Italy with different possible outcomes, including, obviously, the most important one, the better stratification of sepsis risk of patients. I'm not going into details for a matter of time of the study, but what we did, and what actually we are doing with our analysis, is to include the Anatolia gene work, which Dr. Nava will present to you later in the second part of this presentation, with several other, not routinely used approaches, such as, for example, NGS. What is our approach? It's to put everything together, including clinical data, including immunological markers, and try to, with a machine learning approach, to discriminate among that high-risk category of patients, the patients in which this kind of approach may be more clinically useful, which means also more cost-effective. So it's a way also of, using money when we use this kind of more expensive approach. And all this will be obviously analyzed using a machine learned approach. And so the need is to integrate all this data together, and this is also a message to all the companies here. To be effective, right from the beginning, this study they have to be integrated as a team with the clinical part of the final clinical users. So I will call Dr. Gone.
Thank you, Professor Mancini, for your outstanding introduction regarding this topic. Now it's time to going a little bit more into some results that were prepared by our hospital. In our hospital, what we have performed is a study in which our standard protocol for the blood culture analysis, which starts from bottle incubation, then after the blood culture positivity, we seed the different plates, and after 3 hours we perform the identification through MALDI-TOF, and if we have a good score, we perform also the phenotypic antibiograms. We flanked it with a molecular test from direct whole blood. What we have chosen is the sepsis panel bundle kit from Bosfor and Anatolia GeneWorks. This test starts directly from whole blood and is able to detect both gram-positive and gram-negative bacteria with this multiplex PCR test, but also some yeasts, mold, and resistance genes. It's composed by an extraction and an amplification, and all the process takes around 4 or 5 hours with the hands-on time. From November 2023 to October 2024, we tested 104 samples, and we evaluated at the end of our study 96 samples because we reached all the information that we need. These samples were collected mainly from intensive care unit, both the adults one and the pediatric ones, and the patients were enrolled and for their critical condition, and our clinician used the consensus guidelines for sepsis and septic shock with SOFA score. Our results. The molecular test had 56 positive assays and 40 negative tests, whereas the blood culture was positive only on 30 samples. What about the concordance and discordant results? Regarding the concordance, we reached 23 positive samples for both the blood culture and the molecular test, and 33 negative samples both for the molecular test and the blood culture. So we reached 59% of concordance on these 96 samples tested. The 23 positive samples were positive for the same pathogen, but in 8 samples with the molecular test, we detected also an additional pathogen relative to the results of the blood culture, and these pathogens that we detected with the molecular test was also isolated from another specimen of the same patients. Regarding the discordant results that are a little bit more interesting, we found that the molecular test was positive in 33 samples where the blood culture was negative, and in particular we detected 12 Staphylococcus species that can be a contamination, of course, due to the wrong sampling of the patients. We detected also 17 microorganisms with the molecular test that were present in other specimens of the same patients. We detected also 1 yeast in which we had a positive beta-glucan test. And we also see the molecular test still being positive with the treatment of antibiotic, and this means that we had the first sample with a concordant results, and then the 2 following time points, the molecular was still positive, whereas the blood culture became negative. And then we obtained also 7 discrepancies, so the 7% of our results in which we had a negative molecular test with a positive blood culture. In this situation, we have 4 samples where the molecular test was completely negative, and this was a Staphylococcus species. This can be a contamination of the blood culture and not of the whole blood sampling, and then 1 sample where the blood culture was positive for Cytobacter brachy. That is not a target present in the molecular test, so it's not a real false negative results for the molecular test because, of course, it's not in the panel, but it's a difference between the 2 tests, of course. And then 2 negative tests with a positive identification in the blood culture. Then we had also 3 negative tests where the molecular test detected pathogens that were different from the one isolated for the blood culture. And in these discordant samples, the DNA detected was of some microorganisms that were detected in other specimens of the same patients. Some clinical reports that can be quite interesting in the clinical practice. Let's start with this case of 2 twins, newborns with sepsis. The first day, the first twin developed some symptom of sepsis with a positive C-reactive protein and procalcitonin. we received the blood culture, we performed the ground stain, which we detected the positive Kochi. Then, 2 days later, we identified and gave the information regarding the antiphenotypic antibiogram of this Streptococcus agalactiae. The days after, also the second twin developed the symptoms, and with the standard protocol of the blood culture, we gave the identification and the antibiogram of the other Streptococcus agalactiae 2 days later. With this molecular test, we detected from the whole blood, the same day of the arrival of the specimen, a positive test for Streptococcus agalactiae. So we were able to detect the pathogens earlier relative to the blood culture. Then a second case, which is a little bit more difficult more complicated. This was an old patient of 69 years, which developed a septic shock after a second transplant. The first day we received the blood culture that were completely negative. The day after, clinicians sent us other specimen, in particular a rectal swab for CPE screening and also an endotracheal aspirate for carbapenemase screening, and also beta-glucan test. As you can see, we detected an E. coli positive for an NDM gene, then on the tracheoaspirate Eklebsiella pneumoniae ESBL, but also the beta-glucan was positive with 14 picograms per ml. Then the clinicians sent us another whole blood culture that became positive the day after. The gram stain revealed gram-negative rods. We perform a rapid molecular test directly from positive blood culture, which detects an E. coli, a Staphylococcus epidermidis, a Staphylococcus aureus, and then the resistant genes positive for CTXM and NDM. The day after, at the growth of the culture, we detected an E. coli with an NDM resistant gene. The day after, we received another beta-glucan test because this patient was very complicated, and we obtained 615 picogram per ml of positivity of this beta-glucan test. The rapid molecular test on the whole blood of the first day was positive for the genome of Eklebsiella pneumoniae, E. coli with CTXM and NDM that were the two resistance mechanisms, a Staphylococcus species that was also detected by the test performed on the positive whole blood culture, meaning that maybe these microorganisms were not viable, but its genome that were present on that patient. But we detected also an Aspergillus spp. That this can explain why the beta-glucan became so positive and increases its positivity. So in this moment, there are many different possibilities to to increase the possibility of the workflow of the sepsis test. There are many different possibilities. You can perform microscopy with the new microscope that reads directly the smear. You can perform the rapid molecular test directly the same day that you receive the blood culture. Then you can perform the identification after the positivity with MALDI-TOF. There are new phenotypic antibiograms which take less times for also having MIC. So there are different things on the market, and you can improve. We need to improve the diagnostics for sepsis. This is very important because all the new guidelines include the rapid diagnostics as a part of the process for the diagnosis of sepsis. And in conclusion, the rapid molecular test from whole blood can identify metapathogens, but of course not all. They can identify some resistant mechanism, which is fundamental for changing and correcting the empirical treatment the first in the less time as possible. Regarding results interpretation, it's a little bit important to understand how to interpret the low bacterial loads. Maybe we can establish a CT threshold to understand which were contaminants and which were the real pathogens. And the detection of genomes, of course, is a pro, and the cons that you can detect not viable pathogens. This is a cons because you don't know exactly if that pathogen is present or not. But of course, if you have a patient that already underwent an antibiotic treatment, that genome can be the pathogens which is associated to the symptoms. So it really depends on the situation that you have in that clinical case that you are facing. So it's important to establish a dedicated workflow depending on the criticality of the patients, in collaboration, of course, with the antimicrobial stewardship to understand exactly which are the patients to analyze with this test and to be more rapid in the diagnosis. It's important always to perform the blood culture, which is at the moment is our gold standard. And of course, the local epidemiological data are fundamental, because if you are an hospital in which you have many resistances, having that kind of information is very important. Thank you all for your attention, and see you at the booth.